Thank you for that introduction. It will save my introduction a little bit of time because before I begin to talk about prevention, let's see if this works. Yes, I would like to give you a little bit of a background on where I come from. I'm from Altarum Institute. Our headquarters is in Ann Arbor, Michigan. We are a nonprofit research institute that focuses on systems research largely for, entirely for now, health and healthcare related issues. We have about 400 employees, partly in our headquarters in Ann Arbor, Michigan, which is because we're a University of Michigan spinoff, but also largely in the Washington, D.C. area where many of our federal government clients reside. A few years ago, our institute took a look at research areas that we believed were being underfunded, and we identified 4 such areas that we refer to as critical systems issues. Among them are, and as a result, we developed 4 internal research centers that are associated with addressing those 4 issues. One of those centers, the Center for Elder Care and Advanced Illness, is led by Joanne Lynn, who you heard speak earlier today. I'm affiliated with the 4th one on this list, the Center for Sustainable Health Spending, where we try to track health spending and understand what's driving it and what one might do about making health spending sustainable. One area that we've been looking at for almost 10 years now within the area of health spending has to do with the value of prevention. And in particular, I want to talk about 3 issues that we have looked at over the years, which might be phrased as 3 questions. What do we spend on as a nation on prevention? Secondly, what should we be spending as a nation on prevention? And third, are we thinking about the wrong kind of prevention? What is the value of investing in prevention defined much more broadly than clinical preventive services? There are a lot of people who are claiming that our U.S. healthcare system needs to transition from a culture of treatment of disease to one of disease prevention and health promotion. And as a first step in that process, it seemed to us a few years ago that it would be useful to have metrics and methods so we could measure just what we are spending on prevention in order to give us a better understanding of what, in fact, the current distribution of funds is, and to use that as a basis for promoting discussion regarding what we ought to be spending, how we ought to be distributing funds between prevention and treatment. The government's official estimates of national health spending are the National Health Expenditure accounts developed by the Office of the Actuary at CMS. They don't separate out prevention spending. And so there have been previous independent estimates of prevention spending that suggest anywhere between 1% and 5% of our healthcare expenditures go to prevention. However, these estimates are inconsistent in various ways. They use inconsistent or imprecise language to define what they're counting. And a lot of them have turned out to rely on one study whose methods are not readily available and are based on 1988 data. So we thought it was maybe time to do a reassessment of what we do spend on prevention. And the first problem we encountered, which surprised us a little bit back when we were naive about what prevention was about, is just defining what you mean by prevention is a difficult problem. So we adopted a more or less commonly used set of definitions shown here. We talk about primary prevention as interventions to prevent the occurrence of disease or disability. Secondary prevention involves interventions to detect and arrest disease before it has become symptomatic. And tertiary prevention involves interventions to prevent progression of symptomatic disease. So if we're talking about a person with a particular medical condition, or beginning without that medical condition, and that condition extending from asymptomatic to symptomatic to an advanced state of disease, and we're talking just about clinical preventive services here, then various kinds of diagnosis and treatment include secondary prevention if they involve asymptomatic conditions. They are tertiary prevention if they involve symptomatic conditions, and treatment if they are advanced conditions. Similarly, screening involves is secondary prevention and involves people who have either asymptomatic disease or no disease. The purpose of the screening course is to determine whether they have that disease. And various kinds of counseling and immunization activities involve primary prevention and deal with people either with disease not present or asymptomatic. Given those definitions, then what we wanted to do was develop some estimates of what we spend on prevention that are consistent with the National Health Expenditure accounts. That is, we wanted to know how much of the accounts one would carve out and call prevention. Secondly, we want to use precise definitions that are well understood, incorporate an open description of our methods so people can evaluate what we did and pass judgment on it, and provide a time series of annual estimates so you can see over time what prevention spending looked like and how it's evolving. Also to subdivide the estimates into building blocks so that you can put different blocks together. If you don't like the way we define prevention, use different building blocks and use your own definition. And our focus was entirely on primary and secondary prevention. I personally have trouble distinguishing tertiary prevention from treatment, and so we didn't include that in our assessment. So the National Health Expenditure Accounts has 5 major components as shown here. The ones that are shaded in blue, personal health care, public health activity, and research, all have prevention components associated with them, and we were focusing on those. Within personal health care, there are both medical and dental preventive services, and those break out into further categories as shown below. Public health activity and research are also separate categories, and have prevention aspects to them. We used both top-down estimates, for example, for research, estimating the fraction of research expenditures associated with the National Health Expenditure accounts that were associated with prevention, and also some bottom-up development for things like screening and immunization, where we actually looked at individual services and tried to estimate the amount we spend on them and added them all up. And here's what we found. The most recent year for which we've done this so far is 2008, and our time series goes back to 1996. So what you see is over that period a growth in what we spent on prevention, up to a little bit more than, what is that, $200 billion in 2008. Tiny bit of it, the brown at the top, is research. More than half has historically been primary prevention, although secondary prevention has grown as a portion of the total over the most recent years. Here it is as a percent of the National Health Expenditure accounts, and now you don't see growth. Health care spending in general, of course, grows every year. Prevention has barely held its own as a percent of that total, but look where the percent is. It's something above 8%. So the 3% that we've been hearing in the literature in the past is probably an understatement of what we spend on prevention in the country. And again, more than half of it is associated with primary prevention. This is another look at how it breaks out. Here what we've done is we've shown prevention interventions, the blue bar, the second bar down, representing growth over time using the scale to the left to show how much we're spending on preventive interventions, up to about $200 billion a year in 2008. Look at research down at the bottom. Prevention research in particular is tiny and has been pretty flat during that period. Treatment interventions, the red bar at the top, has grown slightly faster than preventive interventions, as you can see the bars separating slightly, but it's on a different scale. The scale over to the right represents treatment interventions, and so while we're spending about $200 billion a year on preventive interventions, we're spending almost 10 times that much on treatment. The work that I've just described is presented in one of the chapters of of this book. But the real reason I want to put this book up here is I think it's a fascinating look, not our chapter particularly, but the rest of it involves the question of what is the balance between prevention and treatment. In other words, what should we be spending on prevention and how should we think about that problem? And it has a series of essays that looks at economic arguments, legal arguments, clinical arguments, arguments from ethics perspectives, arguments from different cultural and religious perspectives, and I think it's a fascinating cross-section of how different parts of our society think about the trade-off between prevention and treatment. So when you begin to think about what we should spend on prevention, people are commonly arguing that we underinvest in prevention, that we ought to shift some spending from treatment to prevention because that would improve our public's health and would also save money. And because, after all, the evidence is only 3% of health spending is devoted to prevention. That's clearly not enough. Preventive interventions are inexpensive, and they prevent very expensive conditions requiring expensive treatment, thereby saving money. And we tend to have a treatment bias that causes us to invest in prevention compared to treatment. Well, in reality, we've already seen that spending on prevention is much larger than the 3% that a lot of people quote. But more importantly, the percent we spend on prevention is not by itself evident that it's insufficient. We need other ways to measure that. And secondly, though, it is true that a lot of preventive interventions are inexpensive. They tend to be applied to a large group of people, many of whom would not contract the condition that's being prevented in the first place. And their costs, if fully counted, include not just the preventive service itself, but subsequent expenses involving identifying false positives, confirming true positives, and treating side effects of the preventive interventions. And when you take all those into account, most preventive interventions don't save money. On the other hand, the claim of a treatment bias does seem to be accurate. Payment systems have historically favored treatment. I understand that Medicare has paid for kidney dialysis since 1972, only began paying for mammograms in 1992, and up to 2005, the only clinical preventive services covered by Medicare were mammograms and pap smears. That's changing, of course, with some of the provisions of the Affordable Care Act and new attitudes about the value of prevention. But historically, we have favored treatment in our payment systems. We seem to have a psychological bias in favor of rescue medicine, depending on the age of the group. Some of you will probably recognize me referring this to the baby Jessica in the well syndrome. Not that we shouldn't have rescued baby Jessica from the well, but it was extraordinarily expensive. And if you think about spending that same money on prevention of disease, we would be better off with regard to our health in the country. We also tend to favor investments that provide near-term benefits, which tends to be true of treatment, to those whose benefits occur in the distant future, that is, prevention. And finally, we tend to favor investments whose benefits accrue to identifiable individuals. If I'm treating someone for a condition, I know that person, I know who that person is. Whereas if I'm pursuing some sort of a preventive measure, I don't know who I'm helping specifically, that is, who would have gotten that condition in the absence of the preventive measure. One way to think about, therefore, the value of prevention is through the concept of cost effectiveness. Are people familiar with cost effectiveness analysis? I'm not really sure what the background of this group. I'm sorry?
The microphone is off.
The
microphone is no longer on. Microphone.
This microphone? Oh, I'm just not close enough to it, sorry. Okay, cost effectiveness analysis. Anyway, it's a common method that we use to measure the economic efficiency of an intervention, where the cost effectiveness of an intervention is the ratio of the extra cost you pay for that intervention beyond what you would do in its absence, divided by the the benefit that you get from doing that. So C minus C0 is the cost of the new intervention minus what you're substituting it for, and Q minus Q0 is the benefit you get from the new intervention minus the benefit you got in its absence. A particular form of cost effectiveness analysis measures the denominator Q in terms of quality adjusted life years, and that's sometimes referred to as cost utility analysis. And there is a very useful registry maintained at the Tufts Medical Center in Boston called the Cost Effectiveness Analysis Registry that combs the literature and actually keeps a large database of now several thousand of these cost effectiveness ratios for many interventions, both preventive and treatment interventions. A few years ago, Josh Cohen and colleague, Cohen is one of the maintainers of the Cost Effectiveness Analysis Registry, used the registry to estimate the relative value of prevention versus treatment for the items that were in their registry, and this chart summarizes their results. You see that a little less than 20% of preventive measures are cost savings. That's what I said earlier. Most preventive measures don't save money. That doesn't mean we shouldn't be doing them, of course. That's also true of a little less than 20% of treatments are cost saving. And if you look across the board there in terms of the grouping of cost effectiveness of the different groups, you see that a little less than half of interventions, either preventive or treatment, are cost $50,000 or less per quality adjusted life year. That's generally considered a bargain, and so on as you go across the board. So what we're seeing is cost effectiveness of prevention and of treatment looks pretty similar if you just look across the different initiatives that are used for those kinds of interventions. And Cohen and company concluded that therefore, rather than arguing we ought to shift dollars from treatment to prevention, that we should instead be looking more carefully within treatment and within prevention in order to understand better where we might be best applying our resources. Looking back to the treatment bias issue that I mentioned earlier, we looked at looking only at cardiovascular disease. We also used the cost effectiveness analysis registry and extracted the prevention and treatment interventions associated with that set of diseases, computed the median cost effectiveness of each of them. Remember, a small value is good. That means you're buying effectiveness for a relatively low cost, so that prevention looks better than treatment in the median value. And yet we're spending roughly 3 times on treating cardiovascular disease as we do on prevention. By the way, prevention there includes, in our definition, treatment of hypertension and hyperlipidemia, which is why those numbers are so high. So those results suggest very weakly, at least, that there may be a treatment bias there, which led us to ask the question, well, what would happen if we shifted spending from treatment to prevention? What we learned is that question is actually complicated by the fact that the effects of prevention spending and of treatment spending interact. To investigate those interactions, we built a mathematical model of the cost effectiveness of alternative spending streams for treatment and for prevention, applied it to cardiovascular disease, to develop insights into what the optimal mix of spending for prevention and treatment would be, how those two interact, and we also included research in the model to understand better what the role of research is in that prevention-treatment trade-off. The model takes a flow of individuals, of a population among disease states from one to the other. I'll show you a picture of it in a minute, and changes the rate at which those individuals flow from healthy to sick to death as a function of the amount we spend on preventive interventions, treatment interventions, and research in prevention and treatment. Let me see. Oh, and we represent population health in terms of quality adjusted life years. developed some equations that, and this is quite abstract, but that represent the transition rates as a function of the amount in which that you spend on these different conditions. So, a very simple model. We have people born into a healthy population. From that population, some people die of other causes, and some become sick with the conditions we're concerned with, cardiovascular disease in this application. From that state, they can die from other causes or from cardiovascular disease. The two little circles, bulbs in the arrows represent what you can think of as valves that restrict the flow from healthy to sick or sick to dead. And those flow rates depend on what we spend on prevention for the first one and on treatment for the second one. Furthermore, treatment interventions also reduce the average morbidity of the people in the sick population. Research in either of those areas makes the effectiveness of prevention interventions better. I'm not going to talk much about research here, but let me say a little bit about the prevention versus treatment here. This is just a curve that shows what the equations do that represent the death rate as a function of treatment spending per sick person. So what you see is as you spend more per sick people, the death rate goes down, but with diminishing returns. If you add research to that, it pulls the whole curve down so that spending becomes a little more efficient. Here's one of the results that came out of the model. If you look along the horizontal axis, what we're showing there is the annual amount we spend on treatment per sick person. And the curve shows then, as a function of that, how much we have to spend to buy a unit of health, in this case a quality adjusted life year. So low values of that curve are good. If treatment spending is low, prevention spending is highly cost effective. That is, the number is quite low. Why? Because we're not doing a very good job of treating people, and therefore we get good value out of preventing the condition. As treatment spending increases, and here we're assuming it's increasing in the most efficient way possible, the cost of preventing gets worse because treatment is better, and therefore it's less important to prevent the condition. Until you reach some peak, and then it goes down the other way. Why? Because we're now getting diminishing returns on our treatment dollars, and in the extreme, we're wasting treatment dollars, and by preventing the condition, you save those dollars. The takeaway here is not necessarily all those details, but rather that you can't talk about the value of prevention unless you understand something about the cost and value of treating the condition that you're trying to prevent. Look at just the blue curve on the top of this thing. Here what we did was vary along, again, the horizontal axis, the percentage of some fixed budget that we allocate to prevention with the assumption that the remainder goes to treatment. What we're counting is the amount of health we're buying measured in total number of quality adjusted life years. So you want that number to be big. And as we spend more on prevention, the curve first increases and then reaches a peak where we'd like to be, and then falls off again as we begin to spend less efficiently on prevention. The dotted line on the left shows roughly what we estimate we currently spend. The dotted line at the peak shows where we'd like to be using this abstract concept of the trade-off between prevention and treatment, suggesting that we probably are underspending a little bit on prevention compared to treatment in that budget. I won't say much about this slide except to say that commonly in cost-effective analysis, one discounts future prevention and future treatment dollars as well as effectiveness. There are reasons for doing that. There are also arguments against it. This simply shows that as that discount rate increases, because preventive results tend to occur farther into the future, you get less value, present value associated with prevention than you do treatment. So there is something of a treatment bias associated with discounting future value. Most of what I've talked about so far have been initiatives that are clinical preventive services, clinical interventions directed at primary, secondary prevention. People when we were doing this work, kept saying, but you're talking about the wrong kind of prevention. And we finally decided we ought to think about that some ourselves and ask the question, do community-based preventive services, particularly primary preventive initiatives, provide better cost effectiveness or cost control for healthcare? These include various kinds of public health initiatives and in general, other interventions associated with improving the determinants of health. Probably everybody here knows what the determinants of health are. McGinnis and colleagues in a seminal paper in 2002 identified 5 domains, including behavioral patterns, social circumstances, the environment, medical care, and genetic predispositions. So behavioral patterns are things like smoking and diet and exercise. Social circumstances include education, income, and other things. Environmental conditions might include the quality of the air you breathe, the water you drink, your housing. And genetic predispositions have relatively little, we have comparatively little ability to control those. They also estimated the impact on early deaths, premature deaths in the United States within each of these domains. Look at the one at the top. Shortfalls in medical care, they estimate, are associated only with a 10% impact on early deaths, whereas behavioral patterns, social circumstances, and environmental conditions together make up more than half of the early deaths in the U.S., suggesting there's some leverage there if we were to focus on those kinds of interventions and call that primary prevention. Further evidence to that effect was in this paper by Choksey and Farley of a few years ago, in which they went back to the Tufts Cost Effectiveness Analysis Registry, looked only at preventive conditions and divided those into 3 classes. Clinical, which is what most of them are in that data set, but there are some that are environmental in nature. They might include, for example, requiring smoke-free environments. Non-clinical person-directed, those are things that aren't done in a clinician's office but are directed at a particular individual. One example is needle exchange programs for injection drug users, and then the clinical ones. And what you see, particularly in the green bars, the environmental ones, is there seems to be some improved cost effectiveness and even cost saving associated with those interventions compared to the individually focused ones. In fact, nearly half of them are cost savings. Nearly half of the ones that are in the registry are cost saving, suggesting again that there's some potential there for improvement. So what we have done is develop some methods by which one can assess and communicate the value of these kinds of interventions, non-clinical primary prevention, including their impact on healthcare costs. We typically do it by synthesizing existing data from the literature or using some data sets that we have developed and importantly characterize the costs and outcomes in ways that are meaningful to different stakeholders. The thought is that if you can convince the federal government, for example, that it's not only helping their population but also helping their bottom line, if you can do that for state governments, if you can do that for businesses, that you have a better chance of getting buy-in and advocacy for improvements in these kinds of interventions. And these different stakeholders have different interests. Their financial implications are different. Their concerns about health are somewhat different. And so we're trying to sort those out and in the course of doing it, we are looking at the value of successful intervention programs. We're not focused on particular programs. We are looking at different possible levels of success and what that would be worth to potential investors if they could buy that level of success. So imagine you're a potential investor and you're approaching a potential investor who has and you have some ideas for an intervention. You'd like to show first that the program would in fact improve some outcomes, life paths, for example, moving someone to a more favorable life path. Secondly, that they would provide benefit to that investor as well. And third, that the amount being requested from the investor would be less than those benefits, hopefully much less. Well, we're focusing on the second of those questions in what we do. So our work is trying to understand how improved outcomes would benefit various investors. To help inform this work, we developed a high-level framework for how to think about investments in the determinants of health. So if you look at the rectangle at the top left, an investment in primary prevention can affect any of the determinants, possibly multiple determinants of health, shown, some of which are shown down below. Some of those are direct determinants that we argue directly impact health. Some of them are what we call upstream determinants that impact health through their effect on direct determinants. These determinants interact very complexly. This is a very simplified drawing of them. The little dashed arrow going to the left at the bottom is intended to show that there is feedback and feed forward and all kinds of interactions among these determinants. But the determinants affect, of course, healthcare costs. They affect health itself. And there are various non-health impacts, which are important because many of these investments, such as investments in education, might have even their principal requirement, their principal purpose being something other than health. So we'd like to capture those non-health impacts. And of course, most interventions cost some money. The idea is to talk about all of those things from the perspective of different stakeholders, and we have built an analysis tool that does that by taking healthcare costs, changes in health, and some of the non-health impacts, and assessing what their value is from the perspectives of different stakeholders. This indicates what the tool does. It takes as input age-specific, so a whole life path impact of a particular intervention on mortality, morbidity, healthcare costs, and some non-health impacts, and has some generic impacts that have to do mostly with the way, telling the model how it should allocate those benefits among stakeholders. Then outputs include the overall dollar value to the three stakeholders we have in the model right now: society as a whole, the federal government, and state government. We also separate out healthcare spending, and we have a couple of additional inputs that are outputs rather that have to do with the health value, how much you might invest, for example, in order to achieve a specific level of cost effectiveness that you're targeting, or the impact on HALE is health adjusted life expectancy. That's basically the number of quality adjusted life years you experience in a lifetime. So you'd like interventions to increase that. The footnote at the bottom indicates that what we have done is partitioned the whole thing into both what we call pre-longevity and longevity components. Some of these interventions, and we'll see this in a minute, extend life. And when you extend life, you get into this funny argument about, well, if you've extended someone's life, particularly an elderly person, what you have done is caused additional costs to be incurred on that person's behalf. And that makes extending life more expensive in some cases. That seems like a perverse argument, and therefore at least it ought to be worth sorting out or separating out how much of what we're measuring in benefit and cost is associated with that extension of life. I won't say much about this except to say that one of the ways that we've developed data for using in this model is through a life course approach, where we've done this particularly for early childhood interventions, where we've developed identified different life paths, actually using education as a marker to distinguish what these different life paths would be. And then the life path has multiple dimensions: mortality, morbidity, healthcare spending, and so forth, for different education levels. So then what we're looking at is trying to get evidence of the extent to which a particular intervention moves someone from one life path to a higher one, and measuring that difference within our tool. That's what this chart is intended to show. The VPAD over to the left is the data set. We're combining it with other literature and data sets in order to understand how life paths might change as a result of an intervention. Let me talk about a couple of applications that we've made of this work. One of them was a sort of a comparative study of smoking and obesity prevention. So let's assume that we have some kind of an intervention that allows us to reduce the number of smokers in each cohort of 20-year-olds by 100,000. That's about 1/8 of new smokers that enter the population every year. Think about increasing the excise tax on cigarettes, or better, the age at which cigarettes can be purchased from, say, 18 to 21 in a state or nationwide. That could have something like this kind of impact. And for comparison purposes, let's suppose we could do something similar for obesity. So let's assume we had some ways of reducing the number of obese children in each 20-year-old cohort by 100,000. So what you have is 100,000 fewer 20-year-olds this year, and they age. You have a new cohort of 100,000 fewer 20-year-olds the next year, and they age, and so forth. We're capturing those effects of the model. First, by estimating their impact on the impact on health and longevity and costs and so forth, and then applying the valuation tool to measure the societal, federal government, and state government